Good evening, everyone, and welcome to our virtual panel discussion today, brought to you by the California Association of Healthcare Leaders. My name is Jennifer Connolly, and I am representing the National ACHE office, and we are thrilled to have you with our event here tonight. Before we get started, I do want to go through a couple of housekeeping items for you this evening. For the purposes of noise control, you are all on mute, and if at any point you want to speak, you may unmute yourself. If you're on the go during today's session, please use the Zoom app, and also make sure that when you sign in, you're using the same information as you did when you registered for this session. This evening's session is worth 1.5 hours of ACHE face-to-face credit. Your credit will be applied to your ACHE record within 2 weeks of this evening's event, and you'll be able to view that credit in your My ACHE account on ache.org. This session tonight is being recorded, and within 48 hours, you will be able to come back into this platform that you're in now to view that recording, which will be available. So now I want to go ahead and start the session by turning it over to Shauna Taylor. Shauna.
Yes, thank you, Jennifer. Welcome everyone to our CalCon virtual series. We're winding down on our virtual series for this year. We have 2 more sessions left, and we'll get into that in a second. Just on the next slide, I do want to just call out that our participants will be muted throughout the session tonight. So please submit any questions and comments that you have via chat. We will be interactive in the chat and answering your questions during the session. We're also offering a 1.5 nursing CEU at no charge. So if you're interested, please message Kieran in our chat. She did a little message in the chat when you logged in, and let her know that you're interested. As we mentioned, this session is recorded, and on our next slide, our 2 sessions that we have coming up to wind down on our CalCon series this year is the on November 5th, Bending the Execution Curve, Successful Implementation of Change. And then on November 12th, we have our Equity of Care. On the next slide, I want to thank our platinum sponsors. Just a shout out to them. We couldn't do this without them. And also on the next slide, thank you. I just would call out to our hashtag Mask Up. We're in a national collaboration with the American Nursing Association to protect and empower others to protect each other through social distancing and masking. So without further ado, I would like to introduce our moderator for tonight, Dr. Edwards Ojeba.
Right. Hi, everyone. Thank you so much for that introduction. Really excited to be here this evening. I want to say a special thank you to CAHL and ACHE for providing this platform to be able to talk about the important issue of physician burnout and how to support physician wellness initiatives. I want to say thank you as well to our panelists, and last but not least to our audience members today. We know that your time is precious and valuable, so we really appreciate that you've decided to spend it with us this evening. So just a little bit more about myself. I am a practicing internist, currently working at UCSF. I trained at Harvard undergrad and Yale for medical school, and then came out to California for residency at UCSF. After completing that, I was hired on as faculty, and after a few years there, actually went through my own period of burnout. I was having a really rough time. I struggled. I thought that I was done with medicine, so at that point, I decided to leave. And it was in having a lot of conversations with other physicians that I realized how common this issue is. And that was really the impetus for me starting Recharged MD, to try to figure out ways that we can address burnout on a systems-based level. And so that's why I'm really excited that you all are here today to find out more about that and to have a robust conversation with others on this call about what they've been doing within their organizations to address this issue. So I want to introduce our panelists who are here with us this evening. First, we have Dr. Anastasia Coutinho. She is a family medicine physician and the provider wellness champion at La Clínica de la Raza. And she'll be telling us a few words about herself. Welcome.
Hi, everybody. Thank you for inviting us, and I'm excited to talk with you all. I am also from the East Coast and did my undergraduate at McGill and my medical training at the University of Vermont before heading out to Santa Rosa and completing my residency at Sutter and the Santa Rosa Family Medicine residency program that's based in an FQHC. And currently I work in Concord in the East Bay and Contra Costa County for La Clinica, and we're starting our wellness program as a new component. And so I'm really excited to kind of talk with you about how, if you don't have a program already, you can kind of get one up and running. So thank you.
Welcome. Next, I'd like to introduce Dr. Preeti Golecha. She is the Associate Chief Medical Officer at Golden Valley Health Center. Dr. Golecha, are you on mute?
Yes, I'm not able to. Okay, now I can speak. Thank
Great,
you.
we can hear you.
So, so glad to be here and happy to join you all. I am Preeti Golecha. I'm Associate Chief Medical Officer for Golden Valley Health Center. We are a pretty big federally qualified health center in Central California across 3 counties. I was born in India and I did my medical school in India, and I moved here to do PEDS residency in Mount Sinai Health Center in New York, and then moved to California and got my first job in Golden Valley Health Center, I think 8 years ago now. And we have gone through multiple different ways of doing physician and clinician wellness program in Golden Valley Health Center. And there are so many things we have learned, and I'm so glad to be here to share all those things with you.
Wonderful.
Thank you.
Thank you, welcome. And last but not least, we'd like to introduce Dr. Peter Yellowlees. He is a psychiatrist and the Chief Wellness Officer at UC Davis Health.
Thank you very much indeed, Viola, and really appreciate being here, and I do hope this is helpful for everybody. As Viola has said, I'm a psychiatrist working at UC Davis, where I've been for almost 20 years. Prior to that, I trained in Britain and then spent a similar amount of time, about 20 years in Australia. I've been very involved with treating physicians as patients for most of my career, and have chaired our Wellbeing Committee at UC Davis for the last, I guess, 11 or 12 years now, and have been Chief Wellness Officer for the last 2 years. I guess my main interest in this area is really at an organizational level, and that's what my role is about. And it's about changing the culture of healthcare, and through that, helping the well-being of all of our physicians and increasingly all of the staff throughout our whole organization.
Wonderful, welcome. So I'm going to be giving a brief introduction to just kind of basic statistics around physician burnout, what we've seen since this COVID pandemic has hit, as well as a brief overview of a framework that you consider when you're creating your wellness program, or to see the efficacy of the program you currently have in place, as well as what we can do to ensure that we don't get burnout ourselves as we are part of these initiatives, because it can be a big challenge. And so before I delve into that, though, we want to hear a little bit more about you. And so we have a couple of poll questions just to see where you are in your physician wellness journey. I think, again, it's wonderful that you all are here today. So it shows that you have an interest in learning more about this area. So first question we have is, how developed is your organization's physician wellness program? So you see options there: no program, early stage, you're coming up with ideas about it, newly implemented, established but no significant improvement, established and improving. So I'll give a few seconds. Okay, so it looks like we have quite the spectrum here, which is wonderful. We hope that there is information during this programming for all of you to learn from. I think it's heartening to see that we do have, a fair number of established programs, and that we are seeing some with some improvement, but also shows that we have room to go on that. So next question. Shauna, can you move to the next question? Or actually, okay, perfect. So how has physician burnout impacted your organization? And you can select multiple answers. Have you seen increased turnover because of it? Obviously, are you seeing greater dissatisfaction? Has it been impacting your patient experience? Love to hear more about that. So yeah, so as we'd expect, we're seeing our physician colleagues are having a difficult time, and I'll be getting into a little bit more how this can impact the greater health system. And last question, how has physician burnout changed since the COVID-19 pandemic? I'm guessing we wouldn't see it reduce, but has anyone seen it remain the same, worsened on your measures or surveys, or clearly seeing it just in daily interactions? All right, so yeah, I'll get into a little bit more, but as we can expect, it's been a critical issue. And again, we hope to delve into some ways that we can start to approach that. All right. So what is burnout? I know we hear about it often in the media and we use it colloquially, but there's an actual definition to it that is made up of 3 different components. This is actually from research from Christina Maslach. There's a Maslach burnout inventory, and again, it has 3 parts. So first part is around this issue of depersonalization. So that's when someone suffering from burnout feels as if they can't really connect with people, and they just see other people as burdens or challenging. So how that might show up in healthcare is you have a physician in primary care, they look at their schedule for that day and they see, 12 patients in the morning and feel like, oh, I just have to get through these visits to get to lunch or whatever that may be. But you have that difficulty connecting with the people that you're caring for. And the second component of burnout is this issue of exhaustion. So how that might show up is people just feel like they have nothing left to give emotionally, physically, and just feel like they really just can't keep up with the duties of their work. And then the third component is looking at efficacy. So this is the person feeling burned out may feel that they aren't performing well, and that they're unable to do their job at the level that they'd want to be able to. And again, this is really the textbook definition that you'll see in research studies. There are other ways to measure it. There's one assessment where you can just ask one question. Basically, you ask the person if they're feeling burned out, and if you say yes, that's a good enough indicator that they're struggling from that. And pre-COVID, what we were seeing is that at any given time, like 50 to 54% of physicians were experiencing some symptoms of burnout. And what we were seeing is that there are differences across specialties. So we tended to see higher rates in primary care, emergency medicine, and OBGYN. And then we were also seeing differences across gender. So women physicians were reporting higher rates of burnout. We're also seeing higher rates in minority physicians. And interestingly enough, we were seeing that younger physicians seem to be having a harder time with burnout symptoms, typically in the first 5 years out of residency. And it's interesting, it's thought to be secondary to kind of the introduction of the electronic health record and all of the administrative burdens that have come as a result of that. But that was one thing that we've been seeing in studies. And then as we'd expect, and as you all are seeing at your own organizations, that with COVID-19, with this pandemic, we're just seeing higher rates of burnout. And this was a Medscape study that was done earlier in the summer. So we can imagine with the second wave coming, going into the winter season, that if we're not intentional about having initiatives to address it, that we'd only expect these numbers to worsen. And then why should we care about burnout? So I would argue that, because our physician colleagues are suffering, that's enough of a reason. We are seeing high rates of anxiety and depression and substance abuse in physicians, as well as seeing high rates of physician suicide. So on average, we're seeing around 400 physician suicides per year. And I think the sad part is, even though we do have access to mental health resources, there's still a lot of stigma in the medical community around accessing this care. And I think part of it is due to the policies that we have in place. So there are questions currently on recertification paperwork asking if a physician has ever received any kind of mental health treatment. And so I think that's a real barrier to people being able to get the services that they need. But I also think it's a low-hanging fruit for us to be able to address some of these policy issues so that we can provide the support when it's necessary. And then beyond that, we definitely see that physician burnout can impact patient care. There have been studies that show there are higher incidences of poor outcomes, medical errors as it relates to physicians with burnout caring for their patients, as well as seeing lower patient satisfaction score. And a lot of that makes sense, because if a physician is feeling exhausted and having that symptom of depersonalization and unable to connect with their patients, then the patients are going to feel that. And so we need to be able to address that for everyone's sake. And then I'll be really quick on this slide. I just wanted to add this to say, pre-COVID, a lot of the burnout we thought was due to administrative burden. So again, with the EHR being initiated, now we're seeing doctors, after having a full day at work, having to now chart for 3 and 4 hours as they get home, as well as increased access to physicians with the EHR. So now you can get a patient message at 2 in the morning and be expected to respond quickly. And so all of that has created a change in that patient-doctor relationship that has been difficult. But now you add on top of that COVID-19, and I think, prior to all of this, there is that expectation that you might be exposed to some risk as a doctor, but not to this degree. So now people are worried about their own safety, and then as that relates to their family members. So it's an incredible amount of stress to deal with. And then you add on just kind of all of the other things that we've been dealing with in 2020 as it relates to race relations, climate change, so being in the Bay Area, the concern around the fires and air quality and all of that, as well as the upcoming election being a source of tension and the political divisiveness that's going on. And then again, the recession. So there's a lot to deal with. And I think one thing that makes it particularly difficult is because of the pandemic, we don't have access to the same coping tools that we would normally use. So just going out with friends or family is impossible. And when the air quality is bad, just being able to go out and take a walk hasn't been available to us. So it was really this period of unprecedented stress, as well as not having access to the things that would typically help us. But I do want to end on a good note. So there is hope around what we can do to change some of these things. And I wanted to put this up there for a basic framework. This is something that I created through ReCharge-MD, just looking at burnout from a comprehensive level. I think historically, we've seen a lot of interventions that are focused on that middle area. So the self and people. So that's looking at yoga, meditation, mindfulness, maybe gym membership or things at that nature, but it's really just focused on helping the individual and not necessarily addressing the upstream root causes of burnout. And so on this, I have it as a way to take a look at what your program is doing and to make sure that you are addressing things in each of these buckets. So that area here around the practice of medicine, that's talking about the operations of practice. Like, are we removing the barriers to providing good care? Are we making our EHR as functional as possible? Do we have a great team structure that can work together where you have everyone working at the top of their license? And then looking at the organizational part. So that's talking about what's the culture like is burnout and wellness, is that emphasized? Is that a priority? Has leadership decided to support initiatives around that? And so that's also going to be an important thing to look at. And then lastly, how we practice within the broader healthcare system. As I mentioned before, some basic policy things that can be put into place around, the licensing, recertification wording. I believe that's been changed already in California. And are there other things on the policy level that we can be doing to make physician wellness and clinician wellness more of a priority? And then lastly, just talking about kind of a personal toolkit. I know with this year, there's just been an incredibly large amount of stress. I know that it's been challenging for me at certain points, and I imagine for everyone, if you haven't experienced some kind of emotional distress this year, like that's kind of expected just with everything that we're dealing with. And so one thing I'd like to emphasize is trying to think about what you can do to make sure you're taking care of yourself. And I know typically in medicine and healthcare, we put ourselves last and we don't have a lot of emphasis on self-care. And I think we're all seeing just the importance of keeping these things in mind, especially as it relates to our mental health. So with that, I want to jump into the panel discussion. And our first question that we want to ask everyone is just if they can take a few minutes to summarize your institution's wellness program with an emphasis on systems level change that you've been able to initiate, as well as please include anything that has changed as a result of COVID-19. So with that, I'm just going to go in order. Let's have Dr. Golecha go first, in order on my screen.
This time I can unmute myself, so that's great.
Perfect.
So I agree with Dr. Edwards on this, and our emphasis has always been on systemic factors. I'm not against meditation or mindfulness, but I think unless the operations around the physician is fixed, it's extremely difficult to focus on mindfulness or yoga or meditation. So what we have done is we have looked at all the factors around the physician, keeping the physician in the center, and saw, okay, what else we can take from your plate, something which you don't have to do and somebody else can take it. And then had the nurses or MAs or QI workers or other people in the team take those things. We looked at all the people's, at what they can do at the top of their license. And then let's take that away from physicians. So there is one less task for physician to perform. Also, I want to emphasize on standardized procedures and workflows for the support staff, because unless it's standardized and written down in the form of policy or procedure, it's not going to happen. So definitely look into that. We created rooming in standards, like if the patient is coming in, what are the basic things your MA has to do for you before you are entering the room? Those things have to be done before you get there. Pre-visit planning, procedures for refill request, procedures to decrease your in-basket request, and your staff to look into those before it gets to you. So you really get time to spend with your patient and actually provide the care you want to provide in that visit, instead of clicking through the windows and finding the chart and doing all the other stuff. So again, my focus is always on systemic issues, and I think that's where we need to really get to first, and then meditation and mindfulness will come next, because at least finally, I think physicians will get time to do all that stuff.
Great. So it sounds like you all have been very focused on the operations part of things and making sure that you're removing the barriers to kind of seamless provision of care. And let's hear from you, Dr. Coutinho. I think you're on mute. Are you able to unmute?
Oh yeah,
okay.
Sorry, it was preventing me from the meeting.
Okay.
So we are kind of at the beginning stages of our wellness program. And so currently what we've been finding is that EHR is a huge source of burnout for patients. We went live on Epic during COVID, which was definitely a stressful time period. And so currently we've been putting a lot of energy, like Dr. Golecha said, into making the operational side, especially in the EHR, as smooth as possible. And so what that entails usually is making sure that the MAs are putting in as much information as they can, updating charts to be as accurate as possible in terms of medications, referrals is a huge source in primary care of just having to put in so many referrals and get all of that information back. And we haven't necessarily gotten everybody linked with all of their other counterparts. So we've been putting a lot of effort there. Similarly, I think making sure that everybody is working to the top of their license is a huge goal for us right now at an FQHC because of a variety of reasons. I think front desk MA staff turnover is a huge issue. People come, they get trained, and then they go off to bigger and better opportunities. And so we're really looking at our staff resources and how can we incorporate staff wellness as a component of provider wellness, because we know that working as a team is really the way that we're going to get the best access for our patients, the best care for our patients, and keep both our patients and our community happy. And that is a huge barrier that we've found. And so still trying to definitely come up with the best ways to do that. But a huge source, I think, thinking about the systems level of change is it's really hard to create consistent wellness patterns or consistent wellness programs if every 6 months your medical assistant leaves or your front desk person leaves and you have to retrain them in whatever program you've been working on for the last little bit. And then finally thinking about, how has that changed during COVID? A lot of different things. Obviously going live on Epic was not a great source of wellness during COVID, but I think also we have a limited number of staff. Also being La Clinica, we have a large Latina, Latinx population. We know that COVID is disproportionately affecting people of color. And so we've had a lot of people calling out sick and really needing to focus on just staffing as a general tool. Moms needing to take care of their kids and help them with Zoom school, having to take FMLA, taking care of people at home who might be older. And so this really huge redistribution of staffing resources has really been impacting us. And then secondarily, with just a limited staff and getting a lot of money from grants, having the medical directors now having to do all of their daily operations, just like everybody else, and fit in COVID tools has been really difficult for us to just not have the financial funding to get more people. And we all know that fitting in more work into your already capped work schedule is a really stressful event. And so just trying to figure out better workflows for how to incorporate the COVID work and still allow everybody to do their own job is kind of a separate caveat to what we're doing. Yeah.
And so it definitely sounds like turnover has been an big issue. And then it's wonderful that you all are focusing on kind of the global wellness of everyone within the team. And hopefully that will kind of bring those numbers down as everyone feels cared for. And Dr. Yellowlees, would love to hear more about your program at UC Davis Health.
Sure. Well, thank you very much. So UC Davis, we're a fairly large health system, and we have about 1,800 to 2,000 physicians at any one time, about half are faculty, half are residents. And the first issue, quite honestly, is getting resources to do this. You really can't do anything unless you've got some people with dedicated time. And so we've been very fortunate. It's taken a long time. We've been arguing about this for sort of 10 years or so. But the leadership at UC Davis really gets this now. And, so we have 5 physicians who are part-time. I'm a half-time, and the others have less time than that. But it's more than the equivalent of 1 full-time physician, plus about 4 full-time support staff, plus our EAP program, which has about 3 or 4 psychologists working in it. So we actually do have resources. And I think that's the first thing to say. The leadership has actually really put their money where their mouth is. And they're to be, I think, really congratulated on that. Because you really can't do anything in this area just by trying to be a nice person and do it on the side. If you're going to make organizational change, which is obviously what everybody's talking about here primarily. So having said that, we look at it from 4 perspectives, so 4 pillars, I guess, that we're working on. The first is to improve access to care for physicians. Fayla mentioned that in her entree, and we know that physicians don't tend to like getting care. So we've got multiple ways of doing that through our EAP program, through our Wellbeing Committee, through the Department of Psychiatry, where we now have 6 psychiatrists who regularly see physicians, both from our own system and from elsewhere. Working with the local medical society to assist with coaches, and in particular, really pushing the process of peer support so that people are prepared to learn how to not only receive care, but also help other people who they see in difficulty. So I think access to care is clearly the first thing you have to do to try and get over the denial that as physicians we're taught to sort of, I guess, learn from day one in medical school. The second area is the efficiency one that several other people have mentioned. So we're sort of doing a lot of work on education, improving people's use of the EMR, inbox activities, trying to reduce pajama time after hours. That's a hard one, and there are increasing demands made on physicians for sort of EMR activities. We then look at the culture as being the third pillar, and how can we change the culture? We've, for instance, developed a physician lounge, which we brought into being about a year ago. That made a huge difference. Having physicians have somewhere to go where they could actually have some private time and meet with each other was a huge benefit. But we've also developed about 60 or 70 of our physicians who work on several committees and who are well-being champions, and whose role now incorporates being a well-being champion. We equally have focused on this issue of peer support. And we've trained about 50 physicians in psychological first aid, so that they can actually effectively deliver that to other physicians. I have to say that that's been primarily originally driven by the nurses. And so we actually have about 300 people in our system now fully trained in psychological first aid. And finally, there's the resilience issue that people have mentioned, and we do all the usual things, trying to make sure that people look after their kids properly, that they eat well, that they exercise, that they sleep well. Sleep's a big deal. So that's a sort of the general program. What's happened during COVID? First of all, we've actually been given more resources. That's the first thing to say. As I say, you can't do anything without resources. So we've had an extra full-time clinical psychologist added to our EAP program just for physicians. And that's been a huge deal. And it's an acknowledgement that a lot of our physicians actually are prepared to go for counseling and get help. We've also had extra resources given to us to scale up our peer support program. And our long-term aim is to use that program to not only have a lot of peer supporters for when people need to vent, but also as part of our cultural change to make people more aware of the needs of other people. So we've been given extra resources for that. And then the third thing that we've done, which has been, again, scaled up and taken quite a lot more time, has been a lot more messaging. A lot more information flow, transparent messaging, truthful messaging, and messaging not just on well-being, but from all of the leadership groups. And we've really taken a view that in the past, we probably haven't kept people informed enough about what's happening within the health system. And there's been a very clear approach by all of the senior leadership to a lot more transparent and useful messaging for all staff.
Great. So thank you for providing that overview of your program. And it's helpful to see, again, the various stages of where we are in the wellness journey, and just kind of emphasizing the importance of having support from senior leadership around these initiatives, as well as having the resources, both financially and then also in terms of administrative support, to be able to do this work. So at this point, we're going to take a question from our audience members. And I'm going to give this one to Dr. Galecha. So what initiatives or policies are being implemented to combat burnout from administrative burnout? Burden, sorry. So I know you said a little bit about trying to shift some of the roles, but can you just say a little bit more about that particular issue?
Sure. And I know, I think that's a great question, because administrative burnout and the time spent at home to get caught up on the charts and, do everything else has been an issue. And we wanted to implement new technology and softwares, apart from, creating procedures and policies. And honestly, we were scared initially, because we were like, oh, we don't want another system which is going to cause more burnout, because like, oh, I have to log into another system now. So what we did is we did round robin. Sorry, I call it red robin somehow. And we got votes from our physicians and providers and asked them, like, what do you really want us to work on for next 6 months? And we did this around 2.5, 3 years ago. And then we kept doing it every 6 months. And we asked them, like, if I could take something away from your plate, what it would be for 6 months and how I can help you get there. And then after we collected all the votes, we picked top 3 and we focused on those. So we created policies and procedures. The first year, I think we created policies and procedures around refill requests, because that was a huge issue for a lot of our physicians. And then we kept looking into that. And then last year we looked into the quality metrics for physicians, because when the patient comes for their visit, it's not the only thing they are bringing to you, but also the other things, like if they have diabetes, you have to take care, check their A1Cs, you have to check their feet and all that stuff. And it took a lot of time from physicians to look into the chart, figure out, okay, what else is missing from the chart? Do I need to do PAP for this patient? Do I need to do colorectal cancer screening? And we wanted to get all that thing printed out and ready for them before they even saw the patient. And we tried different things, like having an MA do pre-visit planning manually. And honestly, it didn't go that well, because it took a lot of time from staff, and we couldn't support the FTs which were needed for that. And then eventually we got into software. And yes, it was initially pain to roll that out, but we created standing orders for staff, so they can actually do login into separate software and print all that out. And eventually we integrated with our EMR, so it's all ready and handy for physicians. So I think the key point here is to keep your ears to the ground. And honestly, so many times we thought from leadership perspective, oh my God, we need to do this next now. And when we asked physicians and providers, that was nowhere close to be close on their list. So we kept asking them every 6 months. And I think that's the most successful program we have implemented. And I don't have a name for that, but just asking them, what do you want next? Like, how else we can make your life easy? And then creating and procedures and policies to support that.
Thank you. So that actually leads perfectly into our next set of questions around, like, how has your program been received? What impact have you seen? And what metrics or procedures are you using to actually measure the impact of the work that you're doing? So I'm gonna give this one to Dr. Yellowlees. And I think you're on mute. Let's have you unmute yourself. Thanks.
That's always very helpful, isn't it? So look, I mean, I think one of the problems in this area is how best do we actually monitor what we're doing, and what sort of metrics should we be looking at. We use Press Ganey. We did the engagement survey of a full one about a year ago. We're actually just this week sending out a pulse survey, looking mainly at physician engagement, but also looking at a number of other issues with other staff. But we're very reticent to send out too many surveys because of all the usual problems of survey fatigue that people have. We don't want to irritate people anymore. But we also look at a lot of our EMR data. So we look at pajama time. We've just done a big project looking at how effective is our physician education, and does it actually reduce the amount of time that people spend in the evenings and at weekends on the EMR? Because we have a full-time education team that goes around all of our clinics. And so we're using that. So we're essentially trying to look at all sorts of different internal data, at physician turnover data, at HR data, at RVU data, and look at that over time. And I think that's in some respects a better way of actually trying to monitor where you are. Than just doing sort of constant burnout surveys, which we all know are going to have people scoring high anyway.
Thank you. And Dr. Coutinho, I'm going to ask for you guys, since you are at the beginning stages of your program, how you plan to measure the impact and kind of a little bit more from that perspective.
Thanks. I think one of the biggest things that we have realized as we are launching our program is that just getting physician and staff buy-in at the beginning is really important. And so while we can look at kind of burnout survey data, and we do have the opportunity now to look at kind of PJ time and that stuff with EHR, the biggest thing that we are trying to do is just get physician feedback. I think our organization has done surveys, and the question this year, now that our burnout program or wellness program is new, is I fill this out every year and nobody ever does anything with it. And so right now, our biggest thing is working on transparent focus to communication of saying, we got this data, being transparent with the data we received, coming up with a strategic plan, having providers and staff kind of buy into that plan, and just really listening to people say, I trust you, or I'm starting to trust you with what you're saying. And I believe that you're even gonna, make attempts to improve, and just really working on that communication piece and getting feedback in that way, rather than using metrics for success. Just like you said, burnout, regardless of what seems to be the intervention, burnout seems to kind of stay at that stagnant 40 to 50%, and there's not much movement. And so really using that as a metric is not as useful, I think, as getting just independent feedback and in conversation.
Sure. So I think just highlighting from that if you are going to be doing these measures and doing the surveys, like making sure that you're planning to actually follow up on it, and that it can actually be harmful just to measure if you're not planning to make it a priority. So keeping that in mind is definitely an important point. And I'm going to stick with you for the next question around how have you found ways to support your efforts in light of the financial constraints during this pandemic, and in light of the center where you're working being the Federally Qualified Center?
Yeah, we've definitely found this super challenging in terms of balancing putting aside money for wellness and really kind of being more at the edge of in the red and in the black with our patient population. And really, I think, like Dr. Yellowly said, recognizing that institutional and organizational leadership support is crucial, and that upfront there might be maybe not as many gains in the financial aspect, but that these are long-term investments that we expect to make, not just in terms of, physician retention, but being able to make patients happier in terms of quality of care, patient satisfaction, productivity. As a physician, we hate to talk about productivity, but for all the leadership people on the call, it's really how we keep our doors open and how we can see patients, and that's an important thing. And so really having organizational leadership support, willing to buy into that. And then I would say we are trying to get as many grants as we can get to be able to fund this work and fund the time. And I think right now, there's a lot of money in COVID resources, and really being able, if you are one of those health centers that might be not as financially able to support these physicians, finding grants that can be used in various ways, I think is really important, because there will always be something kind of new and hip to fund all of the time, rather than just funding kind of wellness supports. And then finally, I would say really working on, for us, serving a 99% Medi-Cal population, as well as a large proportion of undocumented, uninsured patients, really working on just like public health advocacy to make a better healthcare system for all of our patients. That's kind of the long-term plan of how we're going to be able to improve physician provider wellness and patient care.
Sure. So what I'm hearing is just being creative around where to find these resources, even though they might not seem to be readily available, that there might actually be the funding out there given COVID-19 and the awareness around burnout as being a big issue. So kind of taking that opportunity. And Dr. Galecha, would love to hear from you as well, how you all have managed the financial impact and still been able to have these initiatives continue.
Yeah, I would agree with Anastasia on that. It has been extremely challenging, and we are relying on the grant funding a lot as well. And being said that, I think there is a conscious decision made by leadership that this is important and we have to continue doing it and keep our eyes on the long-term goals. Because again, COVID is temporary. I'm hoping the vaccines will be out end of this year or next year. But if we lose a physician, it's going to cost us more than $300K just by losing one physician. So again, there is a ROI in keeping the goal, like keeping the program alive and making sure we are taking care of our physicians too. But it has been extremely difficult.
Sure. And so, with that being said, I wanted to move into the next set of questions. I know sometimes it can be easy when we're talking about these programs to present kind of the polished end picture of what it looks like, but that kind of leaves out some of the bumps in the road that happens along the way. So Dr. Yelis, can you talk about what are some pitfalls that maybe you guys have seen over the course of your program, and how can you help others on this call today to avoid them?
Well, I guess the main pitfall is that, the reality is the majority of physicians are pretty irritable at the moment. Many are very distressed and they're finding things difficult, as several people have already commented on. So you don't want to be going around singing a happy song when that's completely unrealistic. So I think, the single most important pitfall for anyone in the sort of well-being type role is to be realistic and to be straight with people, but to also try and give useful, positive information that is helpful to people and that will do them good. I mean, we send out a message once a week called Good Stuff. We've been doing that for a long time now, and it's an email from my office that I'm very involved in writing along with other people, but it's actually opened by about 35% of people who receive that email. Now, for a central email coming from an administrative position, that's extraordinary to get that level of opening. And we get a lot of really good feedback about the fact that these are straightforward, honest, but helpful approaches. And so, I think you can't kid people, okay? You can't go around and try and sort of, say things as they aren't. And you've got to be very careful to do that. To me, that's the single biggest pitfall. I think the thing that you can do, and that we've done a lot of, is focus on what are the potential advantages and long-term strategic gains we can make from COVID. Now, I think we've actually handled our financial situation pretty well. And so we've done better than many other health systems for lots of internal reasons. But one of the big changes we've made is this transition to video visits. We had a lot of people who knew how to do telemedicine type work beforehand. So we had a good start and an advantage in that, and a long-term reputation in that area. Our goals at the beginning of this year were to have between sort of 1% and 3% of all of our outpatient consults done on video. Now, from March onwards, we've been doing about 15 to 20% of all of our outpatient consults on video. In my own discipline in psychiatry, it's 100%. We are monitoring that very carefully, because we know in the long run that we want to keep up that 15 to 20% of all outpatient consults in all disciplines, surgical and medical disciplines, being around 15 to 20%, because we know that that's going to actually make our physicians more flexible. We know that the patients love it. We're looking at ways that we can maintain that in a way that actually really does give us a sort of long-term strategic sort of goal and a change in the way that we provide our care across our whole health system. So I think there are actually good things you can do, and you can focus on some of those, and not everything needs to be sort of sad and upsetting.
So it sounds like taking advantage of this moment to be creative around our use of technology and kind of moving things forward from the healthcare delivery standpoint. And Dr. Catino, would love to hear from you about any pitfalls when you're starting out the program. I know we saw in the poll originally that there are some who are in the conception stage. So what advice would you give to them?
I think, again, the kind of, as I mentioned before, the biggest issue that we found was in terms of getting trust from people, and really making sure that they understood that now that we had created a position, that there was someone really attending to the wellness piece. And I think a lot of times, right, you can make a wellness officer, a wellness champion, and it's really just a name. And so making sure that you're really putting, like Dr. Yellowly said, putting your money where your mouth is, and that you're really going to attend to the concerns that are brought up from providers. If you create a position like this and really don't give it the attention that it deserves, I think you have the potential to just have, like, a negative impact, because people actually decrease their trust in you. And that would be a shame. I think the second thing is really being attentive to how much time you're putting into it. Again, like, if you aren't willing to put a lot of FTE or resources towards the position, you're not really going to be able to accomplish much. And then it's, again, going to be kind of a disappointment to providers who I think get really excited when they hear things like this, and want to buy into it. And the more that we kind of give them false hope, I would say, the more disappointed they will be. And then finally, I think communication is huge. I think all three of us have mentioned just being really thoughtful about transparent communication. And I think a lot of burnout that I have felt or have heard is just from providers saying that they don't understand what's going on. And it's not necessarily that they're unhappy with what's going on, it's that there's a change, and especially during COVID, everything is changing so frequently that it just seems as though there's a lack of transparency, as opposed to really just not being about good communication. And so really being thoughtful about what does bi-directional communication looks like. How do we give feedback in, and how do we, as a provider, how do we give feedback to upper leadership, and how does upper leadership kind of communicate changes to us? And I think having really thoughtful protocols so that providers know what to expect is important.
So I'm hearing the importance of, when we do have these chief wellness officer roles, and making sure that they actually have some authority and the resources to make some of these big decisions, and then some accountability and more communication around what those changes might look like. And then Dr. Galecha, can you walk through kind of some pitfalls that you've seen, or some advice that you could give to others in your stage?
Sure. And I second Peter on, you are not going to solve the world problem, and don't promise something you are not going to deliver. And, being a fixer, and, you really want to do a lot of things, and it's not going to happen overnight, even with the great intentions and whatever resources you can get. And initially we got really excited, and we're like, oh, we're going to do this and that and solve that, everything. And it's just disappointing if, personally also, and also with people, you're going to lose your trust if you're not going to deliver what you said you would. So what I would suggest is to have maybe a 12-month or 18 months goal, just 2 or 3, and focus on that and just talk about those all the time, because probably that's all you're going to get done in that time frame. It's not a destination, it's a journey, and it's going to take its time, and you're going to go back and forth and fix things as you walk the journey. Another thing I think we learned through the process is it's extremely difficult to please everyone. And a lot of times you'll hear like you try your best and you still hear feedback, and you can't please everyone. And from my personal experience, I think I used to get really defensive, and I used to get sad and then pissed. It's like, oh, I tried everything and I still can't make this person happy. Like, what do they want from me? And it's just not possible. All you can do is listen, really deeply listen and try to help them, and that's all. But you're never going to please everyone in the program. And as long as 80 to 90% of your people are happy, I think you're there.
Yeah, so what I'm hearing from that is just having some realistic goals around what you want to achieve and focusing on kind of the top 2 based on what you're hearing from the people that you're working with, and just kind of going from there and open communication. And then I'm going to stay with you for the next one, and in a minute we'll open it up for audience questions again. But are there any maybe controversial positions or maybe thoughts that you have around burnout that aren't widely shared? To mix things up a little bit.
Sure. I strongly believe in equity, inclusion, and our role as healthcare providers to stand up and advocate, not just for our patients, but for ourselves. And I think unless we have all those values reflected in everything we are doing, we are never going to be there. I mean, I just find it very even hypocritical to say, oh, we are doing so well with wellness and all that, and when we don't have any female board members, that's not the case. But if that's that's just hypocritical. So I think all those things have to be looked at as a holistic approach, and not just, oh, we are doing this systemic things for our providers and physicians, but we don't care about equity or racial factors. So for me, I think those are really, really crucial, and those should be incorporated everywhere.
Yeah, so definitely making sure that you have representation and the voices that are there to make sure that the things that you are initiating are actually helping to
everyone.
Those values, exactly. And so Dr. Coutinho, would love to hear from you. Any thoughts that you have around that? I think you're on mute.
There we go. Thank
Perfect.
you. So one of the big things that I really value in terms of wellness is feeling as though we are making a bigger difference outside of our direct patient interactions. And so I think about activism and advocacy and being able to really use the FTE or give time to providers to feel as though they're making bigger picture changes, whether that be quality improvement, working on a hospital safety committee, or going out into the community and being part of community-based organizations that are, fighting for pharmaceutical reform, payment reform, wraparound services, immigration, any of social justice initiatives. And I think that when we all go into medicine many of us to help people because we love science, and then a lot of that in the day-to-day kind of gets lost. The patient interactions are great, but the system of medicine is really hard to work with. And so I know that I feel more rejuvenated as an individual, and my colleagues feel more rejuvenated as individuals when we're able to really feel like we're making a bigger impact And if there's a way for organizations to be able to fund that or give time to that, I think it has the potential to just, improve that. We talk a lot about moral injury. I'm sure is a word that's come up for many of you, just feeling like you're not able to give people care the way that you want to, and that hurts us as individual human beings and our moral and ethical values. And so I think if we can put some attention and some self-care to that, we have the potential to move the needle or like in a bigger way.
Yeah. So definitely encouraging more empowerment around making some of these bigger changes, but also allowing the time and space to be able to do that is so important. And Dr. Yellis, can you share maybe something that isn't widely accepted around burnout?
Sure. Well, the first thing I'll do is pick up the issue of moral injury. I mean, I've just had an article published by Medscape on exactly that topic. And if anybody wants to Google me and just put in the article is called Where the Choice is Lose-Lose. That's an article that essentially summarizes the sort of history of moral injury. It's a term that's risen in the military, where soldiers had to do things that led to awful circumstances. So, children and families being killed in a war when they weren't combatants. And I strongly believe that a lot of the irritability and difficulty that a lot of health providers from all disciplines are having at the moment is related to moral injury, and the fact that many people are feeling they're having to treat their patients in ways that are not the best. The obvious example is the teams in intensive care units when only 1 or 2 people can come in and their relative is dying. Or when they have to, use video in those circumstances. But there are many other examples of moral injury, which in fact, if you want to go through the article, you can find quite a few of them. And I think that's a really significant issue. And people sort of talk about, is moral injury the same as burnout? I actually think it's quite different. And it's much more specific. And it's something that actually you can do something about. But if you don't recognize it, then you can't do anything. And so I think we should be looking at this issue of moral injury. And I think that with COVID has actually been a very substantial stressor for many people in our health system. And it's not just about COVID, it's actually about those people who haven't been able to provide the care they know people should have had. So, pediatricians who haven't been able to give vaccinations to children and whose children are going to get sick as a result. So unmet care as well as poorly given care. As a consequence of a health system that has, not done well, but in which, many providers have been really heroic, trying to do their best. And so I think the moral injury issue is huge, and it's something that we all need to be much more aware of and think about a lot more. I think the other thing that has been interesting for me is, and I wrote one of my good stuff pieces recently about this, was actually about, bring up Anastasia's issue about advocacy, the importance of voting on your well-being. And there actually is quite a strong literature on showing that actually if you vote and you take part in your community and you get involved, and I'm absolutely not trying to suggest people should vote in one particular direction, but the actual process of voting and being involved in that is actually good for you, good for us all, and is a good approach to advocacy. And when I went to our media people and said that I wanted to send out a detailed message about this to every member of staff, they told me I was going to get a lot of very rude replies, but that they thought it was a great idea. And so it went out, and actually I had almost no rude replies. It was really remarkable. So I think these sorts of issues are issues we've got to start thinking about more seriously in healthcare, because they affect us all.
Thank you for that. And so I'm going to open it up now for a question from the audience that I have here. So one is around the use of scribes. Are any of you in your institutions using scribes currently? And what has that experience been like? I'll start with you, Dr. Galecha.
We do and we don't. So We do have very limited scribes, and we tried to expand the scribe program to all of our physicians and providers, but it didn't work out really well because a lot of our MAs, their typing and the medical vocabulary was not to the point where we needed them. So we tried it and it didn't go well, except a couple of MAs who did really great, and then we kept them as scribes. So we quickly switched to Dragon, and now I'm hearing really good feedback about Dragon. So we are sticking with Dragon for most of our physicians, except some physicians who already had scribes, and that was working well. I wish we could do, we were really excited about the scribe program, but it just didn't work out the way we thought it would.
Okay. And what about for you, Dr. Katina?
We do not have scribes at our organization. Yeah, I would love one, but haven't really incorporated that.
Yeah, I've definitely heard mixed things about the need for all that training up front and introducing another source of error potentially and another barrier between that patient and doctor. Dr. Yelleles, are you guys using scribes?
So we've certainly used them quite a lot, but it's very much on and off. And some people love them, and some people think they're simply not efficient. And I think when you talk to people who have used them a lot, and I personally haven't, then what they say is that if you get a really good scribe, that's wonderful. But unfortunately, not all scribes are really good, and a really bad scribe can just actually slow you down and be a real pain.
Thank you for that. And then outside of Dragon, are you all using any other technology that's been helpful with the EHR or any other thoughts around that? We can stay with you, Dr. Yelleles. You're on mute. You're on mute, Dr. Yelleles.
I know we're having I'm unmuting, and then it's all right. We're just covering each other. So look, we use Dragon, and Dragon's good. I personally don't use Dragon. And when I've been seeing 100% of my patients on video, I actually type as I'm seeing a patient. I'm a touch typist. I think we should all learn to touch type. It drives me nuts when you see people still doing the sort of finger pecking. I think touch typing is just part of being a good doctor. Now I don't type my notes in front of patients when I'm seeing them in person. So one of the big advantages of video is that you can actually, in a socially appropriate way, type all your notes whilst you're seeing the patient. And so that actually speeds up the consultation for me and makes it much more efficient. And that's one of the reasons I keep telling people to carry on using video, because you can actually get your notes done more rapidly.
What about you for Dr. Katina? You guys are just starting Epic, so.
Yeah, no, so I think one of the things, I actually had to look up what touch typing meant, which sounds like just normal, like regular typing to me. And I think that there is, I want to acknowledge that I think there's two it's a bimodal distribution. I think people who are under a certain age, for lack of, I don't know what that age is, but have a lot of technological prowess. And we went live on Epic, and I find that it's, it was super simple, and it's not always intuitive, but it does not take me as much time to figure out how to do things. And I'm willing to play with it. Like, oh, this isn't gonna ruin anything. I can make a mistake, and I can type my note during my visit, but there's also so much clicking in terms of orders, images. You have to use the chart in a way. If I'm talking to a patient about their ED visit, you have to go back and kind of click into a different section to read their ED visit, and you can have two screens and looking at different things. And I find that having a scribe or Dragon is really challenging for that, just because there's so much movement in a primary care setting. And using Dragon, I would have to be very cognizant about limiting the time of my visit and then going and and talking into Dragon. So for me, as a very facile typer. I'm at the beginning of the millennial generation. I find that just using the technology as is very easy for me. I will also say that we have individuals for whom technology does not come at all very easily, and they are very much struggling with the transition of just medicine from paper to more complex systems, and knowing that there's multiple ways to do things, and it is definitely a hindrance to their practice. So for individual people, Scribes and Dragon might be beneficial. Dragon also has the, I think, negative that it takes a lot of time to train for. It was for lack of, it was trained on a male voice who has no accent, and females have a different pitch and accents occur. And so it takes a really long time to be able to train those programs. And so I find that it can potentially be more frustrating to have to do it and then go correct it than to just learn how to touch type and use the EHR as is.
You bring up an interesting point about the Dragon. I think there are thankfully new tools coming out of Silicon Valley around that, addressing some of those issues you mentioned. So I want to switch gears a little bit. I know we talked about some of these things already, but the next question that we have is like what the role of senior leadership is in this work, and is there anything outside of what we've discussed already that you would recommend, because we have a wonderful audience of healthcare executives today. So any other specific advice that you think would be helpful to highlight? I know we've covered a lot already, so if not, that's okay too. So let's start with Dr. Yellowlees for that.
Sure. I mean, I think the most important thing that senior leadership can be is open to these ideas. I mean, I'm fortunate that I can get in to see our senior leaders, as I need to, and they've been really receptive and interested, and quite prepared to follow through with the bulk of the sort of ideas and proposals we've put in. If you look at leaders for the future, and look at sort of some of the management books being currently written, I mean, I've read several times now that the single greatest sort of, I guess, emphasis that a future leader should have in healthcare is to be very empathic. And I think, we need to choose our leaders who have empathy and who are interested in the well-being of the people who work for them, not just in their patients. Now, we're fortunate, I think we have those group of leaders, but they don't exist everywhere. And I think the most important thing that leaders can do is actually to be encouraging and supportive, and to be aware that without decent clinicians, you don't have a decent health system, and you don't have patients looked after properly.
And Dr. Galecha, would you like to follow up with that same question?
Yeah, sure. I agree with Peter, and I would add that it's really crucial the culture. I know Peter mentioned that in the beginning also. I think the culture of the organization and how you're building it, because it's a conscious decision. Otherwise, it will just happen, and you will not have any control. So we are working on our strategic plan for next couple of years, and we really want to focus on how do we become the employer of choice, and people really choose us as their employer, and we create that culture of psychological safety and accountability for our staff and physicians and providers. And we really take care of those who are taking care of patients, because those are the bread and butter of the organization.
Great, thank you. And Dr. Catino, can you round that question up?
I think for people who are just kind of starting their program, all of our organizations are built differently, and oftentimes the chief medical officer and the chief executive officer and the CFO, not everybody is working together and on the same page or in line with the board of directors. And just having a unified approach, I think, is really helpful to starting out a program, having a unified vision about what wellness means. And the investment that the organization is willing to put into it. And then I think secondarily, just speaking of culture, really the people that who are in leadership positions set a lot of the tone for how the organization works. And I think sometimes the people are promoted or put into positions that might not necessarily vibe with the organization's goals or mission. And so if you are already in a position of leadership, being really thoughtful about who are taking on more roles in more leadership positions, because that really does affect everyone below.
Okay, and so we're winding down on time and we're gonna open it up for questions very soon. But one thing I did want to ask each of you is, with all the stress that we've all been enduring during this pandemic, what has been helpful for you personally to stay grounded during this time and take care of your own wellness? So we can start with you, Dr. Yellowlees.
Sure. Well, I'm working from home 3 days a week. I see all my patients from home. I do most of my research, writing, and documentation from home. So I'm in the hospital 2 days a week for essentially a few essential in-person meetings. And I really love that. I mean, I think this flexibility that you suddenly have, the ability to, take time out and sort of walk the dogs, see your wife, have a nice lunch together, and do things you wouldn't normally do. I get a real kick out of walking to work 10 yards from the kitchen to the study. So I actually think that, having learned to suddenly start working more from home has been really good. And I really appreciate that flexibility.
Thank you. And what about you, Dr. Coutinho?
I am probably the opposite of Dr. Yellowlees. I love going to work because I think I also don't have other people in my house to associate with. And so I really, the flexibility is wonderful in terms of, being able to meet different people's needs. I love going to work and just like having that social interaction, but also just, making sure that we as providers kind of foresee the need to take a vacation. And I think for me at the beginning of COVID, I was like, primary care physicians, we need to be here to support everybody and support our staff, and canceled some vacations, mostly because the planes were shut down, but then didn't take a vacation for a really long time and realized, 3 months later that I was totally not in a place where I could keep doing what I was doing. And so I think really being mindful of, even when you are needed, you are not needed if you can't be fully present. Yeah.
Thank you. And Dr. Gletcher, can you let us know what it's been like for you and what's been helpful?
Sure. COVID hasn't been easy for a lot of us, and any of us actually. And I think with my team, being human to human and, actually recognizing the challenges and still amplifying the positive voices, as Peter said, like sending that email or just saying, yes, we all are going through this, and, being each other's cheerleaders has really helped me. Also, another thing which I'm trying is I'm a workaholic, and it's very difficult for me to draw boundaries and not keep working until 8 p.m. So I set an alarm for 5 p.m. And my alarm actually says, would anyone die if I didn't work right now, and whatever I'm doing, or would anyone lose a job? And if the answer is no, I just shut off my computer. And I've been trying this, and it's not that bad. I just get up in the morning and do it the next morning, and it's fine. I think there are very few administrative emergencies, and we just have to remind ourselves that, again, it's a long journey. It's not a destination, and it's not going to change much if you don't do it today. So that has been very helpful for me. I think I've spent so much time with my family, and I've been able to shut off and literally switch off. That's like my visual reminder. Okay, you need to shut off the work and stop thinking about the work at 5 p.m. and go home.
So it sounds like unlearning some of the things that have been drilled into us in training and being intentional about that is really important. So one question that we have, anyone who wants to answer this is an audience question. Is there anything that we could learn about burnout from other countries and how they're handling it?
You know, it's interesting. The countries that, most physicians in most countries have quite a lot of burnout. The group that is probably different from most other countries in the world is the northern Scandinavian countries that seem to have significantly less burnout. They have a very different style of health system. It's a single payer health system. It's a much more sort of community focused approach. And they, as countries, they also do very well on happiness indexes around that the World Health Organization and the World Bank put out. So I guess my view would be we should look towards those Scandinavian countries in terms of both burnout and communal happiness, and see if we can learn a few things from them.
So Dr. Coutinho or Dr. Galecha, do you want to add anything? If not, we'll move on to the last question.
I would just say,
I just second Peter on happiness index. I was thinking about that, and yeah.
And I would say, as a primary care physician, going back to the first question about administrative burden that came from the audience, the amount of my time that is spent on prior authorizations or having to put in referrals because, the specialist can't refer to some other specialist that they want. And so it comes back to me as like an inane waste of time for the system, for the patient, for me. And if we can think about just different ways to structure the healthcare system that is modeled on other countries, it would have a huge impact on burnout. I would say even Canadian Epic is different than US Epic because of the requirements that we have for HEDIS measures, meaningful use, putting in a certain number of review of systems for like reimbursement. And so even their template for Epic is a simpler format. So thinking about things like that.
Yeah, you definitely raise a good point about EHR here being mostly for billing purposes and not for patient care. And so that definitely is reflected in the experience in using it. So for our last question for each of you, just thinking about what's next on the horizon, I'll have you go first, Dr. Yellowlees.
I think we've got to think about sort of the new normal. And it's going to be probably a year or two before we completely discard masks. And I think we have to think of working differently as certainly as clinicians. I think we're going to be using a lot more electronics. We're going to be using apps and phones and videos, and we're going to be using the EMR in a more sophisticated way. And I think the tipping point's over with that. And, patients have discovered that's a nice way of being treated, and they want to continue with that. So I think we're going to change the way we practice quite significantly. I think we are going to be better at communicating. I think we're going to be messaging more and more truthfully and more transparently. And I really like Priti's comments about health systems competing to be the best employer, because there are going to be more shortages of physicians. There were shortages already of primary care physicians and psychiatrists in particular before COVID. I know a lot of those people have either gone bankrupt or retired, and are considering the latter in particular. So I think those shortages are going to be worse in future. And so we're going to have to work more in teams, particularly in primary care with, extenders from a variety of different sources. And so the role of many physicians will change. I think we'll increasingly become teachers and leaders, and we'll be working with groups of people who are providing a lot of the actual care. So I think it's actually quite exciting. I think there's going to be some very interesting changes. None of this will happen unless we can sort out the horrendous financial, awful environment that we have. It clearly has to be simplified. I know there's lots of models around. I'd actually just suggest everybody looks at the Australian model. I mean, I worked in Australia for 20 years, and it has a great model, which is essentially that everybody gets crisis care, everybody gets primary care, so nobody gets stuck. You can all have a primary care physician, but then 50% of the country also pays for private insurance. And can then choose when they have their hip done and things like that. So not too dissimilar to the Canadian system. I think we're going to have to move in those directions, because I don't see that we can afford to ever be in the position we've been in with COVID, where we've had health systems and states competing against each other. I mean, it's just disgraceful. We have to change that. So, everybody on this call are involved in administration. Go forth, guys, and change it.
Thank you. And so we have a couple more minutes, and Dr. Katina would love to hear from you what you see as being next.
I definitely think the reliance on technology, telemedicine, as a result of COVID is here to stay, and really optimizing the workflows for many organizations. It's not something that has been routinely done before. Being in California, Kaiser has had a great model for that for a while, but I know in my own clinic, like I can't get enough bandwidth to do video visits quite constantly, or my patients don't have the appropriate apps on their phone or don't have data that can use that. And so really being able to be thoughtful about how we're using telemedicine, since it's not going away, and how we can use technology to, in a broader sense, home blood pressure monitoring, home diabetes monitoring. How can we optimize those mechanisms to take care of patients? And then, of course, what Dr. Yellowly said about using kind of extenders to physicians and working more in a team. What does that model look like, and who does it consist of? Being really thoughtful about, right now, I think when we talk about team-based care, it's including NPs, PAs, nurses into that, but what do community health workers, what do health educators, including lactation consultants, what does all of that kind of look like in terms of a team? And obviously, given COVID, I think it has also really highlighted the need for mental health support in all of our communities, not just in our, we're talking about wellness for providers here, but, for our patients, for our staff, for everybody, it's so crucial.
Thank you. And Dr. Gletscher, we'll have you round things out.
Sounds great. I agree. A lot of changes are coming, and I think we need to be involved in those changes and advocate what we really want to see, by voting or just getting involved in different organizations at national level, at the federal level, state level, and physicians and I think healthcare executives have to take more active role in what's coming to us, instead of politicians or non-healthcare related people pushing those changes on us.
Thank you for that. So let's see here. Just gonna round things out. 1 second. Okay, yeah, so, thank you for everyone for participating in this talk together. Thank you for all of your questions and for being an engaged audience. And just in closing, wanted to summarize a few things that we've talked about. So as we know, burnout, we can expect it to be on the rise, just given everything that we're facing currently. And just talking about the importance of having systems level changes as we start to do this work. And as we've heard many times today about the importance of having senior leadership on board and open communication as we are addressing these issues, as well as making sure that we are taking care of ourselves in the process. So I want to say thank you to everyone again for being here this evening. Call to action would be thinking of ways that you can apply at least 2 strategies that you've heard about today. One of them could be, if you're looking for things in terms of the framework. So just looking at the process or the program that you have in place now, making sure that it is comprehensive in its approach. And we are all on LinkedIn. So please, I can say personally, please reach out if you have any questions after this or things you want to talk through. CAHL is also on LinkedIn if you want to get to us through that method. And again, we want to say thank you. So with that, I'm going to hand things over to Jennifer to talk a little bit more about the education critics. Thank you.
Thank you very much. And on behalf of ACHE, I really want to thank the chapter leaders that planned this session today, as well as the moderator and our panelists, and for all of you for joining us and for your participation. So before you close out today, we would appreciate it if you would complete the evaluation for this course. So you can find that evaluation in the same way that you came into this event. There's a little tab for evaluation. And you can also get to it anytime by going back to your My ACHE page and clicking on My Online Learning. In that same location, you'll be able to review the recording of this session within 48 hours. And within 2 weeks, you'll see your 1.5 hours of face-to-face credit applied to your ACHE record. So with that, that concludes our session for this evening, and which is copyrighted in 2020. By the American College of Healthcare Executives, all rights reserved. So thank you everyone for your participation.